central northwestern Wisconsin. I've been on the staff at FSC for about 9 years now and part of the anti-violence movement for just over 20. So a little bit about me. One of the absolutely formative experiences that led me to this work was volunteering here in Eau Claire with an AIDS service organization in the 90s. And when I was a teenager, so I was in high school at this time. And it was actually called the Northwest Wisconsin AIDS Project at the time. And then it transitioned to AIDS Resource Center of Wisconsin, Eau Claire. And I think last year it became Vivant Health, but fun fact, still located in the same building, in the same office suite. So this was all largely pre-ART or antiretroviral therapy, which if you caught Jacob Doherty's webinar a couple weeks ago in this series, you might remember that it's the now extremely effective treatment for HIV, which throughout the majority of my early volunteer experience just did not exist. So at the time, things were fraught with a lot of uncertainty and loss, but the experience really not only gave me my first sense of kind of queer community, but without putting a name on it at the time, I think it imparted so many lessons about health equity and the juncture of personal and cultural trauma that throughout my time during anti-violence work, I can't help but noticing a lot of parallel threads with that early activism. And I've always looked for places where those threads are intersecting. And so in 2018, I think it was, I decided to kind of explore this with more intention. And at great surprise to me, I was accepted as an ambassador to SAPG, which is the Statewide Action Planning Group. And it's this appointed kind of delegation to the Wisconsin Division of Public Health, their HIV program. And we assist in the development and implementation and prioritization of HIV prevention and care services in Wisconsin. So it's been an incredible privilege as an anti-violence advocate to be part of SAPG. And I am undoubtedly the least impressive person in the room, which makes it feel like an especially great privilege. And so I wanted to share today a little bit about what I've learned from that opportunity with a focus on advocates' role in facilitating nPEP access for sexual assault survivors at SANE exams, but also taking a look at some other points that should be on our radar as well. All right, so here is the plan for today. I want to start with a little bit of a recap from the first two webinars in the series, just to make sure that we are all on more or less the same page in terms of topic and vocabulary. Then I am going to move into talking about nPEP and SANE exam advocacy, looking at some of the challenges that we might be able to anticipate and address. Then we will move into fostering alliances. So looking at those key partners in our communities that we can engage to promote health and healing for survivors of sexual assault. And finally, I would like to spend some time looking at the intersections of anti-violence and HIV work beyond SANE exams and beyond this very narrow focus of nPEP. All right, so let us move right in to a recap of the first two webinars. So I really would encourage everyone to check out the recordings from the first two webinars in the series that Jacob and Ruthie and Joanna did. HIV basics training for sexual assault advocates, and then the biomedical interventions for HIV prevention. Although I'll definitely be reinforcing some of the information that Jacob, Ruthie, and Joanna covered, I would recommend watching these two webinars for more of a deep dive rather than just repeating everything they already covered in a much more expert way than I could. But let us begin with just some basic definitions. So HIV is the human immunodeficiency virus, which is a virus that attacks cells that help the body fight infection. So the virus can be present in blood, semen, vaginal secretions, in human milk, brain and spinal cord fluid, and amniotic fluid. HIV can be transmitted by sexual contact, so that includes oral, anal, or vaginal contact with a person who is living with HIV and who has a detectable viral load. And HIV can also be transmitted by being stuck or pierced with a sharp object that has blood with HIV present, and from a pregnant or birthing person with HIV during pregnancy or birth or breast or chest feeding to their infant. HIV cannot be transmitted through the air or water, by ticks, mosquitoes, or other insects, through sweat, tears, or saliva, and by just everyday incidental contact like hugging or sharing space with someone or shaking hands or using the same drinkware as someone living with HIV. And hopefully this is very rudimentary information for everyone, but I bring it up because some of these myths about how HIV is transmitted and what HIV is still persist in the culture at large today. So sometimes we'll hear HIV referred to as HIV AIDS, or we even still hear AIDS used as shorthand when people are really talking about HIV. What's the difference? AIDS is acquired immunodeficiency syndrome. So it's late stage HIV infection when the virus has significantly affected a person's body. And fewer people living with HIV today who have access to medical care and consistent treatment actually end up developing AIDS. And I want us to note the emphasis on who have access to care and treatment. We'll return a few times today to the concept of social determinants of health, and that has been brought up several times throughout this webinar series as well. But I really want us to think about all the factors impacting these successful outcomes and who is, in quotes, allowed to achieve these, especially if we remember that the populations who are disproportionately impacted by HIV, as I believe Jacob pointed out, are gay and bisexual men, women of trans experience, Black and Latino men, and people who inject drugs. So what is the difference between HIV and AIDS? Again, AIDS is diagnosed when a person with HIV progresses to a point where their T cells that fight infection drop below a certain level, or they develop one or more opportunistic infections, like herpes simplex virus 1, toxoplasmosis, anything along those lines. And so this should kind of illustrate why it's a misnomer to say that someone can get AIDS or be infected by AIDS. AIDS is a syndrome, that HIV is the virus that someone can contract, which may or may not eventually progress to AIDS. All right, so nPEP, we're going to spend a fair amount of time talking about nPEP today. And nPEP is post-exposure prophylaxis. So it's a course of HIV meds that when they're taken very soon after possible exposure to HIV, they can keep the virus from taking hold in the body. So by very soon after, the window is about 72 hours of a possible exposure. And they're taken once or twice daily for 28 days, which is a pretty long course of medication, at least compared to other prophylactic medications that we might be familiar with. So they can be prescribed by a healthcare provider or at the ER. And we'll talk a little bit later on about the fact that because this is such an emergent issue and time is of the essence, that the ER may be the site where we see the majority of prescribing taking place. I can't speak to that though, specifically. And also PEP or nPEP is only for emergency use. So what is the little N before PEP about? I have said nPEP, I've said PEP. It stands for non-occupational. That means it's not related to someone's work. So an example would be HIV exposure during sex or sharing needles to inject drugs. Occupational PEP or just straight up PEP, I guess they would consider if someone is exposed to HIV during the course of their job. For example, they are a healthcare worker who gets an accidental needle stick or something like that. All right, real quickly, nPEP versus PrEP. They sound very similar and they are very similar in some ways, but PrEP is pre-exposure prophylaxis. So that's a way for people who do not have HIV, but might be at risk of getting it, to prevent HIV infection with daily medication. And so with consistent use, and we always have to emphasize consistent use, PrEP can reduce the risk of HIV infection by 99%. And also because it is taken before exposure, it's not for use in emergency situations, but although it's not something that can be utilized as part of a response to like an acute experience of sexual assault, I think it's definitely important for advocates to be aware of PrEP as a potentially empowering tool for some of our clients as they're looking for options to, regain some agency and control when it comes to their sexual health. All right. Any questions on the vocabulary review? I really do recommend, especially Jacob's webinar, which provides such concise but thorough information about just the fundamentals of HIV.
No questions or comments just yet in the chat, Amanda. So you're free to go ahead.
We're good. All right. So moving into nPEP and SANE exam advocacy, looking at anticipating and addressing some challenges that we may encounter as advocates. So I want us to start with a little visualization exercise, and I promise I won't make anyone do a guided meditation. But just to get us in the frame of mind to approach this topic. So imagine that you have been called to provide advocacy services at a sexual assault forensic exam or a SANE exam. Without overthinking, what are some of the circumstances that would cause you to prioritize having a conversation about HIV and HIV prophylaxis with the survivor? And you don't need to answer out loud or in the chat, but just think to yourself, would the gender of the patient feel relevant to us, or the gender of the person who assaulted them? Maybe age, race, or national origin, where they live, whether drug use was involved. And now that we kind of have an idea in mind of what our immediate response might be, I want to let you know, you don't have to worry. This is not going to lead me to suggest that advocates are responsible for assessing whether nPEP is medically indicated in a real situation or even a hypothetical situation involving sexual assault. But what I would like us to keep in mind is that, like us, patients are going to come into this experience with a whole range of foreknowledge about HIV and nPEP, and from very limited to very familiar. But unlike a patient who's in that moment of raw trauma, advocates really have an opportunity, and that's why you're all here today, to prepare and anticipate questions or concerns, and also to interrogate our own biases that could keep survivors from learning about interventions that might be truly useful to them. All right, I'd like to spend some time talking about potential barriers to accessing nPEP in the context of a SANE exam, and then some strategies for what advocates can do to help overcome these barriers. So a very basic barrier that presents itself is misinformation about HIV. A patient or survivor may be unfamiliar with HIV is or how it's transmitted. They might use outdated or inaccurate language about getting or catching AIDS. They may believe that only people from certain populations are susceptible to HIV infection. And while we know that there are certain populations that are disproportionately affected by HIV, that does not mean that it isn't possible for people outside those identity groups to contract HIV, right? They may think that HIV is only a concern in other areas or other countries. So they might think that AIDS isn't around here. And that is a sentiment that's especially common in more rural communities, particularly in our state of Wisconsin. All right, so some strategies for overcoming that barrier. Use what you've learned in this webinar series. HIV.gov, which is where myself and I know Jacob and I believe Ruthie and Joanna have pulled a lot of the basic definitions, is just a wonderful resource for plain language information about HIV. As sexual assault advocates, I think we're used to running into all sorts of acronyms and jargon, and a lot of us just incorporate these into our speech without giving it a second thought. And I think HIV can be a pretty opaque topic, and it can also include its fair share of acronyms and jargon. But it's so important, especially for those people who are probably experiencing an acute trauma response, to get information that can be easily understood. So, it's more important to communicate information in a basic but accurate way than get bogged down in that highly scientific, technically correct definition and explanation. So a good way to make sure we're doing this is to practice. Think about what some common questions might be and how we're going to answer them in clear and concise ways. And I'll give a few examples of what that might look like later on. And again, we want to make sure we're modeling appropriate and accurate language, but also really unpacking the fears that are being expressed when someone is using maybe this inappropriate or inaccurate language or terminology. And instead of just correcting them, making sure that we're responding with compassion and reassurance. Another barrier that I want to talk about is lack of familiarity with nPEP. So the individual might not know that there's an emergency medication that someone can take to prevent HIV, or very understandably, they might confuse nPEP and PrEP, particularly if they've been watching those same streaming TV services that I am, because they've probably seen a ton of ads for Descovy recently. I don't know if that's been anyone else's experience. So they also might feel like nPEP, because they potentially haven't heard of it before, is too new or experimental for their comfort. And I've also gotten feedback from from survivors wondering, like, why can't they just be tested first before they take the medication to see if they've been exposed to HIV or not? And so while there may be like a baseline HIV test that the patient is given, any HIV infection stemming from a sexual assault isn't going to show up on the test within the 72-hour window for nPEP. So if they receive an HIV test and it's positive, that's going to reflect an existing infection, and nPEP won't be useful in that situation. So strategies for overcoming this barrier. Again, we're returning to using what you've learned in the webinar series. You don't have to be an expert on pharmacology in order to just be able to convey some basic information. And again, we want to validate concerns. These fears are very real, but also emphasize that nPEP is a safe and effective intervention. So some sample language might be, nPEP is new to a lot of people, but I know that your provider would only recommend it when they are very concerned about HIV exposure. What questions do you have about nPEP? And that's not directing them to make a certain choice about nPEP, but opening the door to get their questions answered. So let's see if this GIF works. It does. There's another side of the coin here. We might run into the barrier that the person we're working with is not interested in receiving sexual assault services. So they are familiar with HIV, they are familiar with nPEP, and they only want HIV preventative care following a sexual assault. So why might this be the case? The person might not be equipped to process the trauma of a sexual assault right now. They might need to prioritize other things in their life. They could be unfamiliar with the role of an advocate or see advocacy services as a kind of synonymous to reporting to law enforcement. And they may have low confidence in the competency of advocacy or other responding systems. And so this was some anecdotal information that's like relatively new to me, but was very, very important for me to receive as an advocate. So sometimes a person will come into the ER with the very specific and only goal of obtaining nPEP. And then in talking about this request with their provider, they might mention that this need for nPEP is linked to an experience of sexual assault. And then that sets in motion this whole shift to a sexual assault response framework, and which might include, proactively contacting advocacy. And so that's something that we advocates have worked so hard with ER personnel to kind of like view as the appropriate course of action, right? So to make sure that sexual assault services are just seamlessly available from the survivor standpoint. But then reflecting on that scenario, of course it makes sense for some survivors to like make that disclosure to their medical provider, but not intend to become enmeshed in this larger system of sexual assault services. Because, nPEP, as I mentioned, needs to be started within 72 hours of a potential HIV exposure. And so follow me here, given what we know about like systems of oppression that can keep marginalized groups unhealthy by making healthcare inaccessible, it's understandable that individuals are going to the ER for these emergent needs rather than to their primary care provider who may not exist. So with all that said, there are still some strategies that we can implement here. And the number one strategy is respecting the individual's wishes, not pressuring or coercing a survivor into making choices. And I think that advocates typically don't spend enough time thinking about who we are not seeing present at the emergency department for sexual assault services and why. And with certain populations, again, we want to think about those who are disproportionately affected by HIV. There has been a much more concerted effort to communicate messages about HIV prevention and resources than there has been about the availability of advocacy services. Even though we're talking about populations that are experiencing violence and sometimes at exponentially higher rates. And this I see as a failure on our part, on the part of advocacy, and we definitely need to address it. But in the meantime, while we're making those efforts to build trust and awareness, we also have to respond to a person's stated need. So what we can do in that moment is offering assistance by advocating for their access to nPEP. So that's regardless of their desire for any further interactions or services. Supporting a survivor only as much as is needed to help them obtain nPEP is a valid function of advocacy. And if it's appropriate, if we develop some kind of rapport with this person, if we can sense that they're open to receiving more information, we can then clarify what the role of the advocate is and maybe offer some other ways that we can help either now or in the future. When I started preparing for this webinar, I anticipated spending a lot of time talking about concerns about the cost of nPEP, because I think that is where the conversation with WCASA originally started as well. And it definitely still presents a barrier, but it certainly isn't the only one, and maybe not even the most challenging one. Nonetheless, someone may have difficulty accessing nPEP because they're uncertain about reporting to law enforcement, or they've decided not to report to law enforcement, and therefore they can't utilize crime victim compensation. And I think we've discussed previously in this webinar series, but the SAFE Fund for non-reporting survivor services also prevents cost-related barriers, because while nPEP is considered an allowable expense, they didn't raise the bar for how much facilities are able to get reimbursed for. So it would, almost equal the entire ceiling for the SAFE Fund reimbursement. And feel free to correct me, anyone who has better language for that. But yeah, that's what we're encountering as a challenge with just utilizing the SAFE Fund. We could also imagine situations where the person has medical insurance, but for reasons we're very familiar with in our advocacy role, maybe hesitant or unwilling to use their insurance plan for this purpose. All right, so some strategies. I want to say right off the bat that I'm going to refer folks back to that recording of Ruthie and Joanna's webinar on biomedical interventions, rather than revisit all the available funding resources at this time. So just know that, your mileage may vary with any of the available resources that they talk about, depending on the needs specific to survivors in your community, and also what kind of HIV related infrastructure exists where you are. And that's why I don't want to spend a lot of time going through particular forms and showing how to fill them out, or talking about one pharmacy or another. Just be reassured though that funding options do exist. And advocates and other partners in the sexual assault response process really need to do the legwork to ensure that patients who want nPEP and are prescribed nPEP can get it with as little difficulty on their end as possible. So not needing the patient to be the one pulling all the different strings. It would be great if the process was like other things, largely invisible to them, so they can redirect their focus to their immediate healing needs. But when we do talk about cost and coverage of nPEP related costs, we can figure out ways to incorporate that information into standard conversations about sane exam costs that we are routinely having with survivors. We need to be very clear, though, that a survivor does not need to report to law enforcement in order to receive assistance with nPEP costs. So they may think, you know, well, crime victim compensation is out there, that's just going to take care of everything. I don't want to contract HIV, so I guess I'll have to report to law enforcement just to have my medical needs met. We want to be very clear that that does not have to be the case, and their decisions should not be driven by that factor. And then this is sort of in a little bit reverse order, but I'd encourage advocates to follow the protocols that you've already discussed. More on having those discussions soon with the same personnel or the emergency department. All right, so another barrier, concerns about the medication regimen. They may be worried about their ability to take the full course of medication for 28 days. Oftentimes, we've seen individuals sent from the ER with either after taking one dose or with perhaps 5 doses of nPEP. So even obtaining the medication after they leave the emergency department can be a significant barrier because maybe housing instability or homelessness, lack of transportation resources. They may have an unpredictable or busy schedule with things like work and childcare needs and everything else that comes up in one's day-to-day life. They may have difficulty remembering to take the medication for that duration of time, and they might lack a trusted support system who can give them that reinforcement to continue with the medication. They also might be worried about the recommended follow-up testing. So Ruthie and Joanna talked about how beyond that 28-day course of nPEP, there are also a bunch of other recommended tests, and those happen at regular intervals for up to 6 months from the time that nPEP is prescribed, and that can be really daunting for folks who aren't right in the thick of trauma. And then finally, the act of taking medication, just taking that pill every day for a month can be something that triggers trauma responses in folks who have experienced sexual violence. All right, strategies to address this then. Help the survivor create an individualized plan based on their concerns. So this can include a lot of different features depending on what their expressed need is. It might look like the follow-up care roadmap or a checklist that they can refer back to. Scheduled check-ins from the advocate are sometimes very useful. So those can be for reminders about, like remember to go get your XYZ test, and also for general support. Making transportation arrangements, taking that one piece of responsibility off the plate of an already way overburdened survivor can make a huge difference. And then that emotional safety planning that I know we are all very skilled at for coping with trauma activation. So just like we might coach someone to cope with any activating set of circumstances that they might encounter. We can help them develop those same skills to cope with triggers that come up when they're taking their nPEP. Okay. So, medical mistrust due to maltreatment. That can pose a huge barrier. And this is one that maybe doesn't have an immediate strategy to address, because I think this is one that is largely on us. So patients may have been previously harmed by medical providers due to racism, homophobia, transphobia, ableism, etc. And I think trusting medical providers can also be prohibitive due to experiences with maltreatment for individuals who have previously been classed as, problem patients by the ER, and that can stem from addiction or mental health issues, people experiencing homelessness, or a combination thereof. But I especially think it's important for advocates to look at this harm caused by different iterations of oppression, especially when we see statistics like 10% of transgender individuals report in the National Transgender Discrimination Survey having been sexually assaulted by medical personnel. So that clearly is going to lead to mistrust for incredibly valid self-preservation related reasons. And I also want to direct folks to this article, which was actually authored by several people that I've had the privilege of meeting through SAPG, that I refer to this one all the time. And it is called "A Gay Man and a Doctor Are Just Like a Recipe for Destruction." There is the URL where you can find it. So the specific focus of this article is on experiences of racism and homonegativity in healthcare settings among Black MSM, and that's men who have sex with men, in the Milwaukee area, and how that influences PrEP uptake. But those specifics notwithstanding, the insight from the focus group participants is so illuminating. I really highly encourage advocates to take a look at this. And I do think that advocates, especially white and or heterosexual or cisgender advocates, have a moderate awareness of medical racism and homonegativity. But too often we're attributing this to people's feelings rather than experiences. So I think on the part of advocates, our reaction is often oh, we need to help with offer education and outreach to make folks understand that we are here to help, rather than, oh no, we need to fix our systemic white supremacy and racism and homophobia and transphobia problem, right? So not an easily overcome barrier, certainly not in that one-time interaction with someone at a SANE exam. So that's why the emphasis on listening, not requiring the survivor to disclose details of past medical trauma, but believing that their stated reality is in fact reflective of their actual experiences. And some sample language we might use to affirm the survivor. You are the expert on your own experiences, and I'll support you in whatever you decide. It's my job to make sure all possible options are available to you. What questions do you have that I might be able to help get answers to? So really approaching this from a place of humility rather than dictating to someone what we believe their experience should be. How are we doing on time here? Oh, perfect. All right, so the last barrier I wanted to take a look at is parental consent. Uh, in Wisconsin, people under 18 can't consent to HIV treatment without a parent or legal guardian's permission. And in this case, treatment does include nPEP and PrEP. So advocates, we have to navigate all of the issues that we already talked about as barriers, but now with the added layer of parents who are making medical decisions on behalf of their children. And another barrier that is, part and parcel to this is that it might not be safe for all youth and teen survivors to disclose some aspects of their assault to their parents. We know that discussing the particulars of experiences of sexual violence is extremely difficult, full stop, and different kinds of relationship dynamics like those between a parent and child can make that even more difficult, especially if that relationship lacks protective factors and the young person has not been given a choice in how much information or when to disclose. Some strategies for then addressing this barrier. I'm going to fall back on learning or using what you've learned in this webinar series. So the same explanations of HIV and how HIV is transmitted and kind of demystifying nPEP can be very useful for parents who need to make these calls on behalf of their minor children. I would urge us to respectfully but firmly correct misinformation about HIV, especially within earshot of the child. So youth and teens deserve to have accurate information about HIV so they can make informed, empowered decisions about their own sexual health. And if the parents say something inaccurate or harmful that is left unchecked, that can, be detrimental to the child and their ability to care for themselves in the future. Do not tolerate racist, homophobic, or transphobic language or insinuations from the parent. Again, that child is listening, and therefore also make sure that that child, as much as we're able to do so, leaves that exam with information on how to access confidential services for themselves as well. So they might not have a choice on, how their experience of sexual assault was disclosed. They might not ultimately have a choice on whether they walk away with that prescription for nPEP, but they should be supported confidentially in the future down the road in their healing journey. Okay, any questions on all those barriers? So many barriers, but so many strategies.
We don't have any right now, Amanda.
Sure.
I know that I have one that I'm sort of tabling until I'm going to see if you cover it already. So I'll let you know how it goes. So you can go right ahead.
Cool. So I want to talk now about fostering alliances. I've referred to that foundation that should ideally be established to ease nPEP access for sane patients before they even present at the ER. And to do that, there are some important alliances or partnerships that we need to cultivate with folks in our communities who may or may not currently be engaged with the sexual assault response process. There may be others that are specific to your community too, and you'll want to reach out to them and start those conversations. But here are a few places to start. So this might seem like the obvious one, but the sexual assault nurse examiners definitely need to be in the loop when we're talking about strategies for helping patients access nPEP. So just remember that we as advocates are not going to be responsible for coaching SANEs, or anyone else on, how to do their job or in any way second guessing their medical expertise. But we're having these conversations to really bring them on board in this process for the benefit of survivors. And, obviously SANEs play a critical role in the sexual assault response that involves a forensic exam. So they are a trusted authority. They have both that medical expertise as well as grounding in trauma sensitivity. And they're the ones who assess patient need for nPEP, along with potentially other members of their medical team. And that's based on their health history and also their narrative of the assault. There are definitely areas for outreach. So really ensuring that the SANEs who are part of your team have access to current evaluation guidelines. And I took this screenshot from Ruthie and Joanna's presentation, so apologies if it's a little blurry, unclear. It's an algorithm for medical providers to use in evaluating and treating non-occupational HIV exposures. And it's from the CDC, this larger co-authored, CDC authored document, I should say, which is available for you all to peruse here. It's really kind of dense medical language, but it's a place that you can refer your SANE nurses to get more information on standard approaches to post-exposure prophylaxis. And they do have entire sections that are devoted to nPEP related to sexual assault. I just wanted to highlight, though, this little point in the flow chart. And it talks about instances where a medical provider would have more latitude for kind of thinking about and treating non-occupational HIV exposure. And so this is something that we might want to talk to our SANE partners about, circumstances where they would potentially recommend nPEP, and tease out whether these might be based on any outdated or stereotypical ideas. Some of those things that might have come up for us during that visualization exercise earlier. But if even that feels too outside our lane, we can, number one, get them to watch Ruthie and Joanna's webinar, and that has all these up-to-date resources that speak directly to medical professionals. And we can also come up with a plan alongside them about developing a common vocabulary for communicating with patients in ways that are factual, but also sensitive and trauma informed. So we should be able to talk in a kind of uniform way, a mutually supportive way about elements of a sexual assault scenario that might prompt a sexual assault nurse to bring up nPEP. So we can also have these conversations with our SANE partners on navigating those nPEP patient financial assistance programs and plot out what that is going to look like in the course of a typical sexual assault patient visit in the ER. And so really spelling out what an advocate's role will be, what can be done in advance of the patient even presenting, to make sure everyone's ducks are in a row when it comes to accessing nPEP. And then also bringing up the topic of having immediate 28-day supply of the medication available for patients to take home with them from the ER. And that may or may not be doable, but I think bringing it up as a concern is going to only raise awareness among the SANES about the reasons that we've talked about, why having the full course of medication in hand is so important for medication adherence. All right, pharmacies, the folks who gatekeep the medication. I can probably think of a much less negative sounding way to talk about that, but they are a trusted authority, of course. They have so much proprietary knowledge and all this experience. I think probably a lot of us have had to work with a pharmacist for better or worse to navigate challenges with, you know, medication cost and insurance coverage, and as well as that patient adherence factor. So they are very well versed in how to do that. Some areas for outreach include talking with pharmacies about the role of an advocate, which advocacy might just not be part of their vernacular. They may not even fully understand the sexual assault exam process beyond what their very limited function is. Depending on where your service area is, this, you know, nPEP might not be on the immediate radar of every pharmacy, but I also want to encourage folks to just don't assume that it isn't either, and really seek out those unexpected allies. So for example, I took part in facilitating an LGBTQ community needs assessment a few years ago. And one gentleman who was, you know, had been living with HIV for 30 plus years. He was living in a pretty rural area of Chippewa County, which as a county is pretty rural in itself. And he just couldn't stop singing the praises of his just tiny hometown pharmacy. And they'd done such an excellent job of helping him manage his HIV medications. And, you know, it wasn't because the demand in rural Chippewa County was so huge. I think that this pharmacy had just decided to make a commitment to providing, you know, probably either just this man or maybe a handful of other people with outstanding care. And so seeking those allies and cultivating those allies is an important step in this process. Pharmacies can also maybe be useful for streamlining that access to assistance programs. They may have an in on medication assistance programs and know some workarounds that haven't occurred to us. And again, stressing the importance of that immediate 28-day supply of medication, making that as accessible as possible. And if not, also talking about strategies for getting that medication in the hands of the patient without creating an additional burden on the patient. Okay, and finally, another potential ally, and one that is maybe overlooked, would be HIV service providers. They are not maybe typically included in our response to the needs of sexual assault survivors, but I'm of the mind that they definitely should be. They are a trusted authority as well. And they have expert knowledge on all things HIV related, and that includes those adjacent systems and medication access, of course. Their information is current. It's their job to stay very up to date with the latest information on HIV interventions. And they also might have the trust of members of the community who have been less inclined to utilize advocacy services in the past. In areas, again, for outreach with HIV service providers, again, explaining who advocates are and what we do. Looking at the impact of trauma, not only on a survivor's immediate well-being, acutely following an incident of sexual assault, but the ripple effect on their health and on their relationships and their ability to, function in the community if they aren't receiving those appropriate supportive services. And also sexual assault related processes, options available to survivors, people who are not working doing anti-violence work or don't bump up against us regularly, oftentimes just might glean information from Law and Order SVU, or may half hear semi-correct information when it relates to them personally, or in relation to a news story. So just always doing that education about who we are and what we do is important to cultivating these relationships. And then lastly, I want to take just a couple minutes here to talk about opportunities to think about ways in which our work as anti-violence advocates intersects with HIV work in ways that is not limited to SANE exams. And I have to be pretty explicit when I explain this graphic, because I don't want us to get tripped up with the language like vulnerability or susceptibility. But the reality is that people who have experienced violence are vulnerable to HIV, and not just as the result of HIV and transmission in conjunction with sexual assault, right? I mean, that seems like the obvious one, that HIV can be sexually transmitted and sexual assault involves sexual contact. But there are also vulnerabilities because of the context in which the violence occurs and those resulting circumstances, like lack of control over one's healthcare decisions, diminished confidence in systems being able to meet your needs as a survivor of violence, second guessing your own capacity for self-care, and also the frequency in survivors of coping strategies like substance use. And all of those can create kind of contextual vulnerabilities for HIV exposure. And then so also people who are living with HIV are vulnerable to experiencing violence because of, the same social determinants of health really that lay groundwork for susceptibility to HIV exposure in the first place, right? So there's also the addition of HIV-related stigma, HIV criminalization, and further, people living with HIV also have higher than average incidences of adverse childhood experiences, which may include violence. So this is why cross-training and partnerships between HIV prevention and care and anti-violence movements are so crucial. Some areas of HIV-related services that I see as presenting really great opportunities for these partnerships between HIV prevention and care providers and advocates might include HIV testing sites, needle exchange programs where people who inject drugs can obtain, single-use supplies and then return used supplies for safe disposal, and partner services, which so many people I know who are living with HIV have identified as the partner services notification experience through no inherent fault of the employees, the person doing this job, has been the source of a lot of trauma or compounded trauma for them. So partner services is a function of like local health departments, and they help to identify and locate the sex or drug injection partners of people who have been diagnosed with HIV, and they then inform the partners of their risk for HIV and provide them with testing and counseling and referrals for other services. And my mind goes to immediately, among those referrals for other services could and should be sexual assault and intimate partner violence service providers. So when we start these conversations around potential partnerships, here are some questions that are important to bring to the table. The first one is understanding how policies and practices around confidentiality are similar to or different from our own confidentiality frameworks. And that is just a kind of practical matter that's going to help us figure out how these partnerships can function like in the real world. It is also valuable to ask if anyone using the HIV prevention or care program has ever disclosed or alluded to a history of sexual trauma, and then how that person would respond to that disclosure, either how they did respond or how they think they might respond if something like this comes up in the future. And honestly, I would be surprised if there are a lot of people working in HIV and prevention and care who have not received either a direct or indirect disclosure of experiences of violence. And then finally, really getting curious about what some of the unmet needs are of the people that they are seeing and serving, and exploring whether there are any needs that our program, our services as advocates can help to address. So this is mutually beneficial and capturing potentially overlooked needs. All right, so some possible partnership opportunities. There are many more that exist, but cross-training for staff and these webinars are an excellent first step towards this. I attended a really good training from Futures Without Violence, I believe, lately, that focused on intimate partner violence screening and referral among HIV care providers. So this conversation is happening more and more, and in order for us to work together, we kind of need to be familiar with each other's worlds. So memoranda of understanding for mutual referrals could also be a useful tool, just depending on how things are structured in our community. And we would want to think about having those include more formalized processes for responding to disclosures of violence. So what would happen if someone mentions that they had experienced sexual assault, and the HIV prevention or care provider would then definitely know what to do in that event and how to ensure that the person received services that they needed. And then, of course, really thinking with intention about those wraparound services for shared clients. Something that I know Family Support Center has tried in the past with limited success, but that doesn't mean we can't revisit it, is advocacy drop-in hours. This probably isn't like the time to pilot a similar program because I know a lot of sites are going to have restrictions about who is dropping in at any given time with COVID protocols. But in the future, that doesn't mean it can't be a possibility. Definitely, though, at the bare minimum, including each other's outreach materials on site in our offices, having them available for the folks we work with who might express a need. I think it could be a great idea to have folks from the anti-violence movement offer trauma sensitivity reads of any forms or materials or scripts, policies and procedures that the HIV service organization might have, and work with those providers on how to just be more trauma informed in their approach and recognize situations that might be particularly sensitive for survivors of violence. And finally, a fun one, collaborating on events. And that, demonstrates unity to the broader community and may help increase comfort with each other's client base in accessing the services that both fields provide. So I want to wrap up by sharing this quote from Audre Lorde. Some of my colleagues and I have been doing a study of Audre Lorde's work for the past several months, and so her quotes are always on my mind lately. And I think this one speaks to not only this topic, but so many others. And that is, there is no such thing as a single issue struggle because we do not live single issue lives. So with that, I want to thank you for joining me today and pass along my contact information. And then I am going to stop my screen share and see if there's any questions.
Thank you so much, Amanda. As folks are taking a minute to either type in questions, you're also free to unmute yourselves. I did have one question. You definitely touched on this when you were discussing the partnerships, especially with SANE, nurses who provide SANE exams. And while we have that wonderful sheet and resource from Ruth and Joanna, in which they're able to sort of determine whether or not someone presenting in the ER would be appropriate to provide nPEP with or have that talk with. Do you ever foresee a scenario in which it is the advocate who's bringing that to the SANE the SANE nurse's attention? How do we make sure that we are not unintentionally further traumatizing any survivor by bringing up HIV precautionary measures when it's not necessary, or avoiding that conversation because we're so afraid of causing greater anxiety? And it feels like that's a fine balance there.
Right, absolutely. And I think that's why under the most ideal circumstances, we will have had this conversation in advance with the different folks who are on our sexual assault response team, so to speak. But it's definitely an area of sensitivity. And I know I have been in situations where I found myself wondering, not just related to HIV prophylaxis, but other issues, whether it was appropriate for me to question the judgment of someone who is a medical professional who I have, so much respect for, and also who has a knowledge base that, far exceeds my own. And I think, so because this can be such a delicate subject for patients, I do think it's absolutely appropriate for advocates to voice this concern, and particularly if the patient has indicated to us, if the survivor has indicated that this is a concern for them, then absolutely it is beyond appropriate for us to facilitate that conversation with the provider. If we, having participated in this webinar series and learned a little bit more about nPEP, just think to ourselves like, given my limited knowledge, I wonder if this would be appropriate for this patient's circumstances. I might suggest having that conversation privately with the SANE, just to not create any tension, and also to avoid, potentially harmful things from being said. within earshot of the patient themselves.
Absolutely. Okay. Yeah, I appreciate that depending on the situation can be a fine balance. So thank you.
Yeah, I think the theme that I've gathered overall, and we talked a lot about this last week, is just being prepared. Having it be in those regular conversations, and you just mentioned this, Amanda, having it be a part of those regular conversations. So when you do meet with someone at 2 o'clock in the morning, you are as best prepared as possible and you have all the tools that you will need. So the person you're working with, the survivor you're working with, has all the things that they would like to have for their own support. And I think the 3 webinars have prepared advocates to kind of figure out what those things might be. The pharmacies, the payment assistant programs, having the conversations about the crime victims, I always have trouble saying that, crime victims compensation, and then the Safe Fund, and what that, and those 2 differences and how we can best support. So I think the overall theme that I hope that folks get is that this is something to start prepping for, and being prepared for, and being able to answer those questions.
Right. I truly think that makes all the difference. Just making these conversations routine, making them standard. That doesn't mean, of course, that every patient, every survivor, regardless of medical indication, like has to be offered nPEP. It's going to, there are guidelines that exist for a reason. But we need to recognize that still culturally, HIV is freighted with a lot of baggage, and more so with certain populations than others. But there, I did talk a little bit about that collective kind of cultural trauma. And, even though HIV has been kind of in our area of awareness for 40 years, there is a persistence of some of those harmful earlier and current messages about HIV and stigma that's attached to HIV. And so it really just does take some extra practice to approach this topic if it's something that we don't already have that fluency in or comfort with. And that's okay. I mean, that's how we develop new skills, as we think about them, and we practice them, and over time it's going to become second nature.
Absolutely. Are there any other questions? Any thoughts that you might want to work through a little bit? And like we've mentioned previously, if things come up and any questions you might have before, or during, or not during, after meeting with someone, after you've gone through and thought about this, please don't hesitate to reach out. Amanda put their contact information. They just put it in the chat. So if you have any questions, please don't hesitate to reach out. And if for some reason you don't have Amanda's contact information, please don't hesitate to reach out to Sarah or I at Wacasa. We can get you in contact with Amanda, no problem. So please don't hesitate to reach out.
All right. Well, I'll say thank you again so much, Amanda, on behalf of Angie and I and the whole team at Wacasa, and for everyone who has joined. Your time, your wisdom, your expertise is so incredibly appreciated. So thank you for joining us today and giving us this invaluable information.
Thank you so much.
With that, folks, have a great afternoon.
Have a great rest of your week.
Yes. Okay, bye.
Bye.